This is the ETM Course Podcast. Hello and welcome back to the ETM Course Podcast. Andy Buck here. This episode, we're really fortunate to get a guest on who has recently published a really practice-changing study that I think is going to have a massive benefit for trauma patients. We're talking to Chris Partyka, who is an emergency physician from New South Wales and was one of the main authors of the recently published SABRE trial, looking at Serratus Anterior Plane Blocks for patients with rib fractures. And this is a fantastic study, and Chris was very generous with his time to let us have a chat to him about the study. We talk about the design, the implementation, the results. And I think once you hear Chris talking about it, this should really become part of your armamentarium for treating patients with bad pain from rib fractures. So we're just going to jump into the episode now, and here we go. Chris Partyka talking about the SABRE trial. Okay, welcome to the ETM Course Podcast. We're very lucky to have Chris Partyka, who many of you will know works in New South Wales and published a paper recently, which I think is going to be a real game changer for many people who treat injured patients, particularly those with rib fractures, and particularly those with multiple rib fractures, which can be a real challenge, not just in the ED phase, but in that early acute inpatient phase. It's called the SABRE trial. Chris, maybe you want to just introduce yourself quickly for everyone?
Yeah, good afternoon, Andy. Thanks for having me. I'm an emergency physician in Sydney at Royal North Shore Hospital. And outside of emergency medicine, I work in pre-hospital and retrieval medicine for New South Wales Ambulance.
Yeah, great. So we'll just launch into it, I think. So what was the impetus for getting this trial up and running?
The SABRE trial really came about from our observation working in a lot of busy trauma centres in Sydney, that many of these patients with significant rib fractures would wallow around in the emergency department for many hours with uncontrolled pain. And that was despite getting good, generous opiate analgesia and simple analgesia. Many of them waiting to go to a high dependency bed, but really just not really getting on top of their pain. Around the same time that we were doing that with the early Serratus Anterior block literature coming out, my colleagues and I who teach on the stress course, procedures course in Sydney, we started to do these Serratus blocks on the cadavers for practice. And as we started to see people wallowing in pain in the ED, we started to do the blocks on our patients that were suffering and started to see some really positive benefits for it. At that time, the literature for Serratus blocks was kind of limited to case series and a few case reports. So we felt that a clinical trial was needed, and that's where SABRE was developed.
Yeah, fantastic. And I think I can echo that in my own practice. I was working up in the Northern Territory, and one of our colleagues started teaching us how to do a rectus spinae block, slightly different, but kind of similar. And the first time you do one on someone with a bunch of busted ribs, or particularly if you do one before you go to put a chest tube in, it's just an absolute game changer. You just suddenly stop and ask yourself, crikey, why haven't I been doing this all along? So the study compared the addition of the Serratus Anterior block to a protocolized or a standard care bundle, which is obviously the stuff you mentioned, lots of opiates and things. Obviously, different places would have done that differently if it was a multi-site study. So what sort of things were people getting in the standard care bundle that you were comparing the block to?
We chose that standard care bundle because we think it really represents the standard of care for these patients. And this came out of the work of our colleagues, Kate Curtis and Stephen Asher at St George Hospital, which really showed that these bundles of care improve both pain scores and respiratory outcomes in patients with rib fractures. And so the broad categories in these bundles are pain management, so simple analgesia, often opiate-based patient-controlled analgesia, access to pain specialists and anesthetics as an inpatient for consideration of regional anesthesia as well. But then there's physiotherapy for rapid mobilization and chest physio for these patients and respiratory support. So each institution had slightly different nuanced differences, but those broad categories were applied. And we thought about standardizing that for each site, but there was already established practice at the 8 participating centers for SABRE. And we thought maybe in a pragmatic trial that would probably strengthen the generalizability of the results. So we kept those pathways as they were.
So again, I've sort of found with patients with this much pain, even things like PCAs can just be hard for them to use, hard to comprehend, especially maybe slightly older or more frail patients. Do you think there was any sort of reason you might not want to do a block in patients, or there was, anesthetic reasons or pain service reasons? Why did you get any resistance, I guess is what I'm getting to doing blocks as opposed to the standard bundle?
One of the real benefits of this trial was the collaboration that we had at the 8 sites that we had involved. And that extended through to not only the emergency medicine teams and the trauma teams, but our anesthetic and pain colleagues on site. They were really on board with the project from the get-go. And in fact, some of the pain colleagues helped finesse the technique and really tightened up the protocol. So in my mind, it always felt like the right thing to do for these patients, particularly if we could reduce the amount of opiates in our older patients. As you alluded to, there's a lot of people that they want to avoid the amount of opiate that they have, and so they're reluctant to push the button even when they're in significant pain. And it probably also comes down to how we measure their pain at the time, and these people are just sitting there saying, I've got 2 out of 10 pain, but they're panting away with very little chest wall movement, which I think confounds a lot of the routine pain scores we have in these patients.
And why did you choose the Serratus Anterior Plane block over other blocks like the Erectus Spinae block?
The Serratus block came to us, again, as I alluded to, as just something that we'd been practicing in our educational side of our work. So the procedures course that we teach on, we'd started to learn that technique. But also one of the motivations behind the SABRE trial was trying to get on top of the pain early. And in many of our trauma centres, our patients are lying around in spinal immobilisation for many hours on end waiting for their CT report to come back. And so the benefit we saw of the Serratus block was you could do that early on, as long as the patient could move their arm up and above their shoulder and expose that axilla. We could do the block well before formal clotting results were back, before their spine was cleared. And so it gave us that ability to do those blocks in the first hour or two of the trial.
Yeah, I think, and for people that aren't familiar with the techniques, as Chris has described, this is just a great technique for someone that is flat on their back because they don't have to move. You can just abduct the arm and you get access to that area of the side of the chest to do the block, whereas things like an Erectus Spinae block, you can do it, but you have to roll the patient on their side, use ultrasound to find some transverse processes of the thoracic spine. It's the rib junctions. It's a bit harder in someone who's already got busted ribs and then you're rolling them. I think that's a great description, Chris, and a good choice for this study. So I might get on to some of the details about the study now. So yeah, there was over 500 patients eligible that you initially documented, but probably less than half the eligible patients were enrolled. I think about just over 100 in each arm. So do you think that has sort of affected the results at all, or did you get enough to actually, get a good power calculation and make the results significant?
Speaking about the power calculation, we were working towards a total of 210 patients from the outset. And that was a predefined number that we were chasing based on some local Sydney-based pain outcomes for patients receiving these bundles of care. And we were quite kind of cautious with the number that we wanted to get a significant result. The fact that we had so many eligible people that missed out on the trial, I think this speaks to a couple of things that were happening, both with the pragmatic nature of the trial and the COVID pandemic that was in and around the time that we were doing the work. We were careful with designing this trial that we wanted it to be whether the block worked, not whether a large group of emergency clinicians could do the block. So we defined a group of qualified clinicians for each participating site and just had a niche group of people that could do that block when an eligible person arrived. And we did that as investigators. We trained everyone up. It was against a standardized checklist to demonstrate competency for each of these qualified clinicians, just to standardize the intervention. So you'll see many people that missed out on enrollment in the trial with just because a qualified clinician didn't happen to be on shift at the time that they presented to hospital. As a pragmatic trial, as well as we all remember across Australia in 2021, right in that thick of the Delta wave of COVID, we were distracted with other competing priorities. And when we were just flat out, I guess people just weren't thought to be important to enroll them in the trial. So unfortunately, people missed out.
That's fair enough. I think it's an amazing feat to have pulled this off in those circumstances with everything else that was going on, particularly with people's chests in that environment, and a lot of trauma. We're still finding it now, but I guess a lot of trauma patients coming in with incidental COVID or with COVID concurrently, and a lot of confounders. And so, just talking about the outcomes that you're aiming for, then one of them was a pain reduction at 4 hours. And again, I think there's a lot of these pain scales are validated for use. How did you decide on that being the primary outcome?
I think as a group of emergency physicians, we're often motivated by short-term goals, aren't we? And we know that patients with rib fractures often don't get good control for several days into their admission. But what we wanted to see was, can an early block have an early impact on pain score? And then we would follow these people up for 24 hours and see if that effect lasted. We approached the Clinical Trials Network of ASIM, who were an amazing resource as we sought to get their endorsement for the trial. But our senior colleagues in that group were brilliant in terms of guiding our primary outcome measure. And so we decided on this composite pain score that we'd measure at 4 hours to be patient-oriented or patient-focused as best we could. So the two components there were a pain score reduction, and we wanted our patients to see a benefit of 2 or more points out of 10 from their baseline pain score, which we thought would be a clinically meaningful reduction in their pain. But then some of the other Australian-based literature suggested that a pain score of less than 4 out of 10 is one that's less than moderate in severity. And so we thought the combination of those two things would be patient-oriented enough, combine that with our timeline of 4 hours, and that's what we settled on.
I was pretty amazed actually to get through the sort of details of the paper and find a number needed to treat of 5, which again, for people that aren't used to listening to number or thinking about numbers needed to treat, that might sound like a lot, but in fact, that's actually really small, isn't it? I mean, that's a pretty amazing result.
Yeah, we don't have many other tricks in our toolbox in emergency medicine that is that effective.
And so can you talk us through some of the secondary outcomes? Because there was a bit of a list there, and I think there's some really important ones about ongoing opioid requirement in particular, I think, which was that's obviously a concern that if the block wears off, people might end up needing rebound analgesia or something like that. Other things like delirium, pneumonia, needing a second block. And then obviously the stuff the bean counters are interested in around length of stay and ICU admission, etc. Can you maybe just give us some of your thoughts about those secondary outcomes?
Yeah, happy to. I think the first thing to say is these are all hypothesis generating. We didn't power the study to look at the secondary outcomes. But the one that you alluded to that stood out was the opiate consumption through 24 hours. And we saw an obvious split in the analgesic requirements of these patients as early as 4 hours, but that really extended out through to the first day of admission. We measured that in the way to balance it through, we used a milligram of morphine equivalent. And so in our control arm, the median amount of morphine used was 90 odd milligrams. The addition of the Serratus block by the emergency clinician halved that amount of opiates consumed in 24 hours, which you can only think would benefit particularly our older patients that are admitted that are likely to get complications of excessive opiates. The rest of it was all pretty equal, actually, surprisingly. We looked at things like delirium, overall length of stay, and respiratory complications, including the need for respiratory support or hospital-acquired pneumonia. And there was no difference between the groups in that.
I noted that 13 patients received a rescue block. Can you talk us through what that means and why that happened for those patients?
Yeah, that was a predefined intervention for us in the control arm. And we went backwards and forwards for a long time in the design of the trial to figure out, should we do a placebo control or not? And we were lucky enough that one of our colleagues had worked with a team in Canada looking at Serratus blocks for mastectomy patients in that perioperative phase. And the safety profile of a serratus block leans itself to many people just saying, give me the block. I don't care if it works or not, because it probably isn't going to do me any harm. And so we felt that we would probably hinder our own recruitment if we were going to do a sham block. To therefore provide some help to the control group that were not going to get the block, we wrote into the protocol that the control patients at 4 hours that had uncontrolled pain would be eligible to a rescue serratus block, as long as the obvious qualified clinician was still available. And surprisingly, only 13 needed it, but that was going to confound our secondary outcomes. So everything that happened after that time was measured by both an intention to treat and a per protocol analysis.
And I guess, did you notice any major downsides or adverse events or unexpected outcomes in the treatment group who got the blocks? I mean, I'm thinking around things like respiratory depression or the block not managed, the block not working enough, or ending up in ICU for any reason, or having pain crises when the blocks wore off.
It's interesting that you mentioned the pain crisis, because that was one of my fears going into this. And I think if we both go back to our anesthetic time in emergency medicine training, we do blocks in that perioperative phase and follow our patients up the next day. And not surprisingly, they've been wailing on their PCA as the block wore off in the middle of the night. And that's interestingly something we didn't see in the SABRE trial. So long after the effect of ropivacaine would have worn off, these patients weren't having rebound severe pain. And when you look at their pain charts or their PCA requirements, they weren't using those excessively at that 8 to 24 hour mark. So that's something that we probably can explore down the line about why that may have prevented the rebound hyperalgesia. But the block is so safe, there's no real other complications. And I think so long as you've got good needle guidance with your ultrasound, as long as you steer away from the pleura, and if you can see it, the thoracodorsal artery that can cause some significant bleeding if you hit it, it's a pretty safe technique.
And did you find any change in, I mean, it wasn't one of your documented criteria, but if there was any change in need for things like med calls or ICU admissions or any other downsides for patients who got the block?
Not that we heard anecdotally anyway. And certainly there was no deteriorations to ICU, which we didn't report on, but certainly that was part of the safety process that our hospital-based teams were going to let us know about.
So it sounds like, on the whole, it's really safe, isn't it? And it's just a really effective technique. And again, anecdotally, the first time I did a different block, the rectus spinae block, was on a patient who we had trauma patient, blunt chest trauma, obvious small pneumothorax on his chest x-ray, but you could see several broken ribs and this delay to getting him around to CT, and we were tossing up whether we were going to do a chest tube or not, and we just learnt the block technique. So we put the block in while he was waiting to go to CT. That transport of that patient and the sliding on and off the table is one of the easiest I've done because of the lack of pain. And then obviously, as you usually find, you'll have a much bigger pneumothorax on the CT than you could see on the chest x-ray. So all said, yeah, he needs a chest tube. And for a patient with, probably I think he had 5 or 6 displaced rib fractures on that side, it was one of the easiest chest tubes I've ever put in. He had this huge field of anesthesia, almost no pain. I put extra local in just in case at the site, but just that, when you're pushing on those broken ribs and things, he just didn't react at all. And it was like a light bulb came on for me. I thought, God, why are we not doing this more frequently for these people? It's such a different experience for the patient.
You've just described a sequence that I think is really important and one that I encourage now in my own practice. And if you have multiple rib fractures and the need for a chest drain, to put the block in before the drain goes in is important. But I think for those listening, it's important to remember that the pleura isn't affected by the block. So having some additional local at that time is important for the drain insertion.
That's a great tip. So I know what I think about this. And we mentioned off air that we're already actioning some practice change at my place of work based on this study. But do you think this study is enough to support change in practice in the wider ED community for people treating rib fracture patients?
Absolutely. I'm a little bit biased, but if you take a step back, the primary literature for our fascia iliaca blocks that we do routinely for neck of femur fractures for every older patient being admitted, that's not as convincing as what the SABRE trial shows. And I think as long as we think about it as an analgesic adjunct not as a replacement for standard care, but something that might just improve pain control, reduce opiate consumption in those patients, and think of it as a bridge between the emergency admission to their subsequent pain specialist review the next day. It absolutely fills a gap in the pain management for these patients. And I don't think it has to be in a big trauma centre. I think there's applications in a rural and regional setting where it might prevent a patient being transferred. And certainly in our retrieval service, we're doing them in a pre-hospital setting now for some of those really long retrievals that we're doing. Even on a primary scene, if we have an extended transfer to a trauma centre, and watching patients have a much more comfortable journey in the back of a helicopter or an aeroplane, particularly in periods of turbulence. So I think it's absolutely translatable to what we're doing across the board.
That just sprung to mind as you were talking about that, the retrieval patients as well. And I used to, still do work for Careflight in the Territory. I'm based back in Melbourne now, but for those patients in the northern half of the country and some in, I guess, New South Wales as well, where you work potentially, very, very long transport times, multiple moves between trolleys and beds and assets from, the scene to the ambulance to the helicopter at the other end, multiple bumps and things. These poor patients bouncing around with their broken ribs and often getting dosed up on things like ketamine, which, on paper looks good, but often when you talk to patients who've had lots of ketamine with lots of fractures for transport afterwards, they'll often describe the fact that they could still feel the pain, they just couldn't say anything about it, or it wasn't quite as good as we think it was looking at them because they weren't complaining. But I think something like this is it's an excellent technique to have up your sleeve. And it's funny, isn't it, that I know definitely where I work, for all the fractured neck of femur patients, they aren't allowed to go to the ward without a block in. That's sort of one of the checklist items to get an off patient out of ED. Yet we've been ticking and flicking rib patients with a little PCA pump who are still moaning and groaning. So I think that's an excellent analogy. So do you think for people that are going to be thinking now about implementing this as a treatment in their hospital, have you got any advice around getting a guideline or protocol written up, which, involving other departments? I think you mentioned, getting anesthesia, trauma, ICU, other people on board. Any tips around that?
I think just opening the conversation with those other specialty teams is important. I think it's something that as a group in emergency medicine, we can train ourselves in. I think having a standardized method of training that is incredibly important. And the governance around that, I think, is equally as important. But as long as our inpatient colleagues in trauma and intensive care and anesthesia are on board, I think that's totally fine. I'm still in my routine practice now. If I take handover of someone with uncontrolled pain at 8 a.m, I'll seek out my pain colleagues to see if we can get a catheter placed during business hours. So I think as long as you're having a pause point and contemplating whether your block will influence the downstream effects for your colleagues, that's important. But if there's no one else around who can do that technique, I think it should be in the realm of emergency medicine, just as long as everyone else is on the same page.
Yeah, and you mentioned some good points there around quality assurance and things as well. The governance, I think, is important. Having a standardized procedure, it's signed off by everyone. You have an audit process, and you're actively following these patients and making sure that you're not doing any harm or there isn't any unexpected consequences that you're having. I guess that's one thing we didn't really touch on is one of the alternatives to this. You mentioned the catheter-based techniques, which the anaesthetists do on these patients usually the next day or the day after when they're really sore on the ward, that I guess some places will have available as an option, but like you said, usually that's an in-hours type of technique. And I guess it's an interesting sort of concept, isn't it, that I think we've touched on this several times, this potential fear that the block will wear off in the middle of the night. Just so you've got a patient who's in it between 8 p.m. and midnight who's not going to get to the ward till midnight to 2 to 3 a.m, where an anaesthetist might not be around, or they won't be around. They're going to be busy in theatre and not accessible to do things like a catheter-based infusion technique. There was potential fear around that, but I think you've really busted that myth, and that's probably the time where these patients could potentially really benefit from this. And I think you've demonstrated that really nicely, that in fact they don't tend to have rebound hyperalgesia. They tend to actually just use less painkillers for up to 24 hours. So I think that's a fantastic result from this.
Thank you.
All right, Chris, we might wrap it up there. Look, thank you so much for taking the time out. I know lots of people have been asking you about this study, and it's just so well done. I think where I work, people are really impressed by the design, the implementation, particularly like we said with the the challenges of COVID and things. Getting anything done in an ED then was amazing, and to hopefully really have the downstream benefit here for patients. I think that's a real point here. It's a good technique for us, and everyone loves mucking around with ultrasound and learning new skills. But I think there is a whole cohort of future chest trauma patients here who are really going to benefit from this. So I think it's fantastic work.
Thanks, Andy. And if I could just acknowledge my colleagues who made this happen during COVID. We recruited ahead of time, and I think that's a massive achievement for them. So thanks for having me today.
No worries. Well done.
Thank you.
So thank you for joining in and listening to that fantastic interview with Chris. I'd just like to give another shout out to Chris for taking the time out to talk to us today. We did talk off air a little bit about this procedure and what things you can do if you're thinking about implementing this in your workplace. And Chris did mention things like making sure that if you're implementing a new procedure that you get your departments on board, that you have your quality assurance and audit practices around it set up properly, your governance, and also credentialing for the procedure, which is an institution-based concept, really. You can't really get credentialed for anything on a course as such, but there's ultrasound champions in most departments now. Most of us have been taught how to do things like fascia iliaca blocks, but it basically involves making sure you document how you want this procedure done, getting a couple of champions in your department, usually some ultrasound keen FACEMs, will be the leads, and they can start training people up and getting people credentialed. It usually involves a process of not so much a see one, do one, teach one, but doing a few supervised by the trainers in your department and then getting signed off to start doing this. And I think the more people you get credentialed for this in your department, the better. Like Chris said, they missed some people in this study because they're accredited proceduralists who were study members weren't available to do this for patients. So, yeah, I think the more people you get trained up in your department to do this procedure, the better. And Chris has also mentioned that he's potentially going to be putting out some work soon describing a credentialing process for this. And as soon as that comes out, we'll be sure to post that on the ETM website. So we're going to wrap it up there. That's just a fantastic new Australian study that we'll put a link to in the description. Encourage everyone to download, read it, distribute it through your department, and start doing this on your injured trauma patients. Okay, and lastly, I just need to mention, for those with an interest in emergency toxicology, you can actually head on over to our new online course website at etmonline.com. That's etmonline.com, where we have launched Module 1 and Module 2 of the Tox course. Module 1 covers common tox presentations including opiates, quetiapine, paracetamol, benzos, SSRIs and SNRIs, and the old exam classic tricyclic antidepressants, as well as an introduction to emergency toxicology, and we give you an approach to treating the poisoned patient. Module 2 is the recreational drug toxicity module, which pretty much all of us working in ED deal with on a daily basis, and it covers introduction to recreational drug toxicity, gamma-hydroxybutyrate or GHB, MDMA and LSD, white powders, which is cocaine and amphetamines, inhalants including amyl nitrite and nitrous oxide, cannabinoids, cathinones, vaping and nicotine, and stimulant-induced movement disorders. It's a massive module, super practical, heaps of great, useful tox tips that you'll be able to use on the floor on your next shift. We also recently recorded Module 3, which should be out by the end of the year and covers aspirin, digoxin, calcium channel and beta blocker toxicity, ADHD medications, which are becoming increasingly common, and these include methylphenidate, dexamphetamine, clonidine, and guanfacine. We also cover gabapentinoids, baclofen, as well as decontamination and enhanced elimination techniques, including use of activated charcoal, whole bowel irrigation, urinary alkalinization, and dialysis. Another massive, practical, really useful module. We also have a very exciting special guest for the upcoming toxinology or bites, stings and envenomation module due to be recorded in September. And again, we'll aim to try and have this out by the end of the year. May push back to the start of next year by the time we get all the editing done on Module 3. Module 4 is going to be massive as well. We'll try and get it out by Christmas. If not, it'll be early 2025. For those that may be not so interested in paying for the online courses but want some free content, that's fine. We've got plenty of that as well. We've got a new free FOAMED Tox course blog and podcast out now. where we delve into all things tox related from a practical emergency medicine perspective. And you can find this at our new website, which is toxcourse.com. That's toxcourse.com. Or just get onto Apple Podcasts, Spotify, or your favorite podcast player and search for Tox Course or the Tox Course Podcast, and it'll come up there. We're also in the process of developing more emergency medicine and trauma-related online course content for etmonline.com. So if tox isn't your bag, keep listening to the podcast and checking out the ETM Course and ETM Online websites for news about our new courses as they're released. So look, that's it for this episode. Thanks again for listening, and we'll catch you on the next episode of the ETM Course Podcast.